Hello, everyone. So the clock has struck 5:30, so we know what that means. We are ready to get started. So welcome and thank you for joining us. My name is Kendall. I'm going to be hosting the webinar this evening. We are very excited about the topic. Dr. Cooch is going to walk us through a few patient cases. The session is going to be a great camera crash course for all of you, so hold on tight. We'll also be asking for your participation tonight throughout the webinar, so please don't be shy. We want to hear from you. So before we get into the good stuff, I have a few housekeeping items to get out of the way. If this is the first webinar that you're attending with us this year, you may have noticed the meeting room looks a little bit different. We have transitioned to a new webinar platform with the hope that it provides a better user experience for all of you. So please give us feedback as we continue to improve our program over time. As mentioned already, your input during this webinar is going to be key. We'll be asking you to vote in some polls. We'll be posing some questions for you guys to answer. And most importantly, if you have questions during the presentation, please type away. This includes questions about content. If you're having technical difficulties, we are here to help. There will always be a Q&A box on the screen, so please feel free to use it. We have a wonderful team of people on our end that will chat and troubleshoot with you. Okay, so with all of that out of the way, I would like to introduce Dr. Kim Cooch, our CEO and founder of CariFree. Dr. Cooch has a pretty impressive resume, and we are lucky to have him as our resident camera expert. He has published over 100 papers in journals. He acts as scientific advisor on dental caries for the Coy Center. He reviews for multiple journals, including JADA, Compendium, Inside Dentistry, and he's been practicing 39 years now. So this only begins to scratch the surface of what he's done for the world of dentistry. And without further ado, Dr. Cooch, the stage is yours.
All right, thank you, Kendall. And I'm excited tonight for this presentation, and it's going to be interactive. Like Kendall said, we've got a new software platform, for our room tonight. So we may have a few bugs in there, but bear with us. We'll get through this. But I'm really excited because this is going to be interactive. So for the first time, rather than just providing you with information, I'm actually going to be able to walk you through cases and have you make the diagnosis and start to think this way. So what I really want to do tonight is not just give you information, but train you on how to think when you see patients. So learning objectives for tonight: upon completion, you'll be able to identify the major risk factors for dental caries. You'll be able to describe different caries management strategies, including some coaching language, and you'll be able to implement a caries management strategies targeted to patient-specific risks. I was fortunate enough in 2001 to become part of the first Camera Coalition, along with John Featherstone and Doug Young and a whole host of educators and researchers, some well-known and wonderful people. I was the lone clinician on this committee, and it was our goal as a group to make caries risk assessment kind of standard of practice or standard of care in the profession. And we targeted the schools, and of course I was mostly interested in trying to figure out how to work this in my own practice. So camera for me represented a quantum leap forward in terms of how I'd been looking at this disease. The challenge was by 2003 we were publishing articles in the CDA journal. We'd created risk assessment forms based on Featherstone's work, and while what we created may have worked in a dental school setting, what I found was it was just way too complicated, way too cumbersome to really work in a private practice. So I spent the first couple, 2-3 years making this complicated. I've spent the last 15 years trying to make it uncomplicated and to trying to simplify it so that it works in my practice and should work in your practice as well. So one of the things I published in 2014, I recognized a regular kind of pattern of this disease based on these basic common risk factors. And so I started to look at patients differently, and that's kind of the thinking that I want you to start thinking about tonight. So as we go through this, we made it really complicated, and it really should be a simple process, and so we have these usual suspects. So when we look at this, we did a study of about 12,000 patients over a period of 3 years. We collected Caries risk assessment forms from 6 private practices, and we collated all the data. And this was based on a form not too unlike the brand new form we're going to share with you tonight. And on that form, the patients self-reported their risk factors, which is a huge step in terms of if you've ever tried to convince a patient that they thought that you thought they had something they didn't perceive that they had. It's a much better situation to have the patient self-report those things to you. And in that, 63% of the patients self-identified that they felt like they had a dry mouth at some time during the day or night, and or they took at least one prescription medication. 55% of the patients in this survey indicated that they either eat too much sugar or they were eating too frequently. 46% of them identified that they had noticed a plaque buildup on their teeth, and 51% of them had a high Caries screen score. We estimate that genetics plays a role of about 30% in dental caries, but at the end of the day, dental caries is a biofilm transmissible dysfunction disease that's characterized by prolonged periods of low pH that results in net mineral loss from the teeth. So at the end of the day, this is all about pH in the mouth. So this is the new Caries risk assessment form, and it looks a lot like our previous version, except for we tried to simplify it to make it more understandable for everybody that's using it. So basically, if you have only green answers, they have no risk factors and they have no disease indicators. If they are all green, this is a low-risk person, and so this equates to the CDT code D0601. If they have at least one blue answer, so that's a risk factor. If they have at least one risk factor, they're moderate risk, and that's a D0602. And if they have at least one red answer, that makes them high risk. And we get lost at times trying to come up with the diagnosis. Like the most important part of this form is to figure out, are they high risk, low risk, or moderate risk, when in reality, everything that's really important on this form is above that little gray line in the middle of the page, because that's telling us why the patient has cavities and why they have cavities, why their teeth look the way they do. That's the entire answer on how to solve this disease problem for that patient. So let's just look at these real quick before we get into these 4 cases tonight, and let's talk about saliva. You know that 63% of the patients have self-reported have a dry mouth. What do they look like? Well, typically, they don't have any saliva. You look in there, there should be saliva pooling in the vestibules. There should be saliva bubbling in the back by the molars. There should be saliva bubbling through the interproximal areas. The tissue should be wet. So when you look at a patient like this, the first thing I see is, where's the saliva? The teeth are dry, right? I mean, this is a patient who has not enough saliva, xerostomach. And if you look at the Caries risk assessment form, this is the #1 suspect. It's the #1 question at the top, and it's even marked saliva. So that if either one or two of these answers is yes, that patient has a salivary issue that they've self-reported to you, and it's identified as saliva. So this is the most likely risk that you're going to see. You're going to see it in 2 out of every 3 patients. I mean, if you stop and think about the data here, you can walk into the room and you look at the radiographs up on the screen and you see decay. 2 out of 3 times this patient has a dry mouth. And this is across all age demographics, because 70% of Americans are taking at least 1 prescription medication per day. 55% are taking 2 or more, 20% are taking 5 or more. We've got 17 million adolescents in the United States on psychotropic drugs for anxiety, depression, and ADHD. And that's absurd. And I was just reading a CDC report 2 weeks ago that they estimate between 30 and 40% of all adult Americans are taking a prescription that one of the side effects from it is depression. So we look at all the things that are going on with behavior in this country, and it's like, hello. I mean, we're over-medicating on a lot of these situations. But the fact that you see these people, they come in, I saw one today, taking 5 medications. She's 67 years old. She had a stroke 2 years ago. She had no decay up until that point in time. And I'm trying to scramble to figure out how to save 6 teeth for her. So, I mean, and that happened in a span of 2 years. So saliva is a huge risk factor. If we talk about diet, and 55% of the people in this large cohort indicated that they either eat too much sugar or they're eating too frequently. And if we talk about how much sugar Americans consume, when I see somebody that has a dietary issue, so the pattern for this disease is they have saliva. You can see it, bubbling and pooling in the back of the mouth here. The tissue's wet. They have saliva, but the issue here for this person is the decay is everywhere. It's spread. You have class 5s, class 1s, class 2s. You've got decay everywhere in the mouth. When I look in a mouth and I see decay just everywhere, it's spread all over the mouth. It's not in one particular region. It's not just class 5s on an older adult. It's not just class 3s or class 2s. It's not any of that. It's spread everywhere. This person has a dietary issue, and so that's a pattern for this disease. As soon as you see that, I immediately know I'm dealing with a dietary issue. And if we look at the Caries risk assessment form, those are the next 2 questions, and that's labeled as diet in that gray bar. So again, if you see one of those 2 answers yes, you know that you're dealing with a dietary issue. And again, for your hygienist or your assistant, these are clearly labeled. So it's like, okay, we need to talk and ask this person more about their diet. Are you drinking liquids other than water more than 2 times a day? Do you snack between meals? If you snack 2 times or more between meals, that increases your risk because you're messing up the Stefan curve and the recovery, the pH recovery of the mouth by snacking too frequently. So that's a huge risk factor. Americans eat 23 teaspoons of sugar a day. And I always challenge people, go home tonight from this webinar and go to your kitchen, pull out the bag of granulated sugar, measure out 23 teaspoons into a baggie, and take it to work with you. Take a look at what that looks like because it's shocking, and take it with you. Have it to show to patients. This is what we're eating every day. On top of that, Americans eat 51 pounds. We're number 1 in the world in high fructose corn syrup. We introduced this into our diet in the U.S. in 1981. We're number 1 at 51 pounds per person per year, and Mexico is number 2 at 32 pounds. That's how far off the chart we are on this sugar. And sugar and diet are a very big risk factor for dental caries. The World Health Organization says that we should consume no more than 10% of our daily caloric intake from sugar. 23 teaspoons represents somewhere between 20 and 30% of caloric intake for the average person. So we're way off the chart there, but the World Health Organization says, and if we were really being honest, we shouldn't really consume more than 5%, and if we were really, really being honest, we shouldn't consume more than 3%. 3% would be 2/3 of 1 teaspoon. So measure out into a separate baggie 2/3 of 1 teaspoon, and then hold that up with the other baggie, and that's the shock that I think we need to help our patients see, because they don't see the sugars and they don't understand that that's how much they're eating. And so sugar is huge. If we could ask the patient, or could ask the right question in my mind, if we could ask the question, is more than 10% of your caloric intake every day based on sugar, I would bet the majority of patients would answer yes to that, and we know that that would increase their risk. In fact, this number, instead of 55%, could be 80 or 90%. So if we look at the biofilm itself, typically, and you see these patients, they have a lot of plaque buildup on their teeth normally. Now, you will see patients, if you use the Caries screen meter, you'll see people that have fairly good oral hygiene, and they have a very thin biofilm, but it's highly active when you go to measure the ATP. And so these people are at high risk. They've got not as many bacteria, but the behavior of the bacteria they've got there are producing a lot of acid. So where's this at again? So this is the number 3 on our risk assessment form. Is clearly labeled as biofilm. If you get a yes answer there, you know that you're dealing with a risk factor. You need to talk about either home care, primarily their home care, right? We assumed that dental caries, when I was in school, I think this is still being taught at some degree, but we assumed that this was a disease of mutans streptococci, and then followed by invasion of a lactobacillus. And I got to tell you that is totally antiquated. 40% of the people in the United States that have severe dental caries don't even have strep mutans in their mouth. So it's like this is a disease of a biofilm itself. And the biggest news in the last 2 years in research is the identification of Candida as playing a significant role in dental caries. Candida is extremely acidic. I mean, they survive in a pH of 4, and so these are organisms that we need to add to this. So it's not just bacteria, it's yeast and it's Candida as well. And when we talk about genetics, what does this look like? Well, there's only one. I've shown this case a lot of times. There's only one geographic pattern of dental caries in the mouth that we can attribute to genetics at the moment, and that is to the lysozyme, the lysyl 2 gene. And those patients only have decay on their mandibular incisors, which is a very unlikely expression of dental caries. These are the 6 most protected. These are the last men standing. These are the most protected teeth in the mouth. So to see only decay on those teeth, that's really unusual. And you may have never seen it, although chances are you've seen it and didn't realize what you were looking at. I've got 3 patients like this in my practice now that I've identified. But beyond that, we know that there's maybe as many as 50 genes that have been identified that play a role in dental caries. I don't have the ability right at the moment to look at your DNA and start identifying these on a patient, and so it's kind of a wild card. If you come up empty-handed on everything else and the patient has tooth decay, you got to assume that the genetics is playing a role, and we know that it plays a role about 30%. The challenge for us as dental healthcare professionals is we only play 10% role in the overall health of the patient. So it's like, it's why we're fighting a huge headwind here is, genetics is responsible for 30%. We're only able to balance this, shore this up with 10%. So if you stop and think about this for a second, anytime you walk into that operatory and you got a patient sitting there and they got decay, 2 out of 3 of them have a saliva problem. I mean, so here's your mantra: saliva, diet, biofilm. I mean, this should just go into your brain. Every time you walk into the room, think saliva, diet, biofilm, and it may be one of those or it may be all 3, as we're going to look at some cases tonight. But think saliva, diet, biofilm in that order, because that's the order that we tend to see them in. Now, if you stop and think about this, most of your patients, a majority of patients, have a saliva and a dietary issue. So the only thing standing between that patient and dental caries is their home care, their genetics, and you. So I want you to stop and think. Just think saliva first, followed by diet, followed by biofilm. And those drive your treatment strategies. So if they've got a saliva issue, you want to keep the mouth hydrated. You want to add the neutralization in there. Put them on some alkaline products that are going to replace the lost saliva. You're going to want to add some calcium phosphate, in my mind in the form of nano-HA, which is biomimetic for what's in the saliva in the first place. If they have a dietary issue, you need to talk to them about what sugar-sweetened beverages they're drinking, how often during the day, how much sugar, where is the sugar that they're consuming, how are they snacking, and you need to dig deeper to help them understand what's causing this disease for them. If you suspect they have a biofilm problem, you want to talk about either using an antimicrobial agent or helping them support their healthcare, their home care habits. And if it's genetic, you just want to help make sure they understand that they're very susceptible to this disease, and you want to minimize the acidic exposure, those episodes, and just support overall wellness. So my protocol for low caries risk patients, now remember, these are low caries risk. They have no risk factors. These are healthy. Unfortunately, this is a single-digit percentage in most of the practices that I've looked at. But so once a year, I have them fill out a caries risk assessment form, because these risks change over time. They start taking new medications. They change their diet. Human beings are very complex, so I want to know every year what's going on in your life, and I educate the patients about why that is so. I'm going to offer them a fluoride varnish at least once a year. I'm going to offer them some pH xylitol, nano-HA fluoride products and strategies, and then I really just want to educate them about risk factors. If you got a moderate risk caries risk patient, again, same thing. This isn't always. A caries risk assessment form once a year. For me, I use a biometric. I use the caries screen. I'm going to offer them twice a year fluoride varnish, and again, I'm going to now recommend that they're using some of these products. And then I'm going to talk about behavioral coaching about the risk factor that they have, risk factor or risk factors. But so at least so that they understand that what's putting them at risk for getting cavities. They don't have any right at the moment, but without addressing those risks, they're at risk for getting decay, and kind of help them understand how they can mitigate those risks in their lifestyle. And then for the high caries risk patient, again, same thing, caries risk assessment once a year with a biometric, always putting them on a fluoride varnish at least every 3 months. That's where the research is at. I'm always going to put them on a pH xylitol nano-HA fluoride strategies. I may or may not use an antimicrobial strategy. I probably will. I may or may not use silver diamine fluoride. That's really patient dependent, what we're trying to accomplish, but certainly I've been using that for years, and I have great success with that material. And then at the end, also, I want to talk about behavioral coaching and target their risk factors and help them understand, again, how they can mitigate those risk factors and get healthy. So let's start with patient number 1. Meet Darcy. She's a 44-year-old female. She comes into my practice. She's got normal blood pressure. She's anxious. She's got kind of an elevated pulse. She's taking a couple of medications, atenolol and Lasix for hypertension. She has extreme dental fear. I mean, she's crying, and she's recovering from alcoholism. So these are the main issues, coming up on Darcy coming in, and I just want you right now, look in the mouth. What do you see? Again, I'm looking for those patterns. Is there saliva pooling in the vestibule? There's a lot of saliva bubbling in the back of the mouth. Is it bubbling through the interproximal areas? Does the tissue look dry? So I'm looking, number 1, again, start your thought process, saliva, diet, and biofilm. So number 1, I'm looking at saliva. Number 2, do I see decay spread out all over through the mouth? And then number 3, do I see a lot of plaque buildup? Obviously, she's got a lot of stain on her teeth, but do I see a lot of biofilm buildup? So that's what I'm thinking as I sit and look at Darcy. So let's look at her x-rays. I think you can see the cavities, the decay, the lesions that she's got that are present. She's had a lot of restorative dentistry done in the past. She's missing some teeth. So that's looking at her radiographs. So let's look at her risk assessment form. So are you taking medications? Yes, and we knew that. She's taking atenolol and Lasix. Both of those are going to contribute to dry mouth. Do you feel you have a dry mouth anytime during the day or night? Yes. She said yes. She's telling you, I have a saliva problem. Number 2, diet. Does she drink something other than water more than 2 times daily between meals? So she's telling you she's got a dietary issue. She doesn't snack. We look at the biofilm. She doesn't really notice a plaque buildup on her teeth. So I want to know where your thought process, where are you kind of headed for Darcy here? What do you see, and what do you think the issues are? Well, if we look at her Caries screen score, it was high, so we know we've got a highly active biofilm. So we've got a biofilm issue here as well. So she has new progressing visible cavities. She's got new proximal radiographic radiolucencies. She's got new or active white spot lesions, and she's got a concerning decay history. So what's going to be your diagnosis for this patient? And if you answered high risk, you're right on the money. So this is a high-risk person. And now let's look at what is your assessment. So I kind of gave it to you there, but what are you looking at? Saliva, diet, biofilm. So here's the assessment. We know that she has a dry mouth from hypertension medications. Turns out she sips coffee all day long with creamer and sugar. Okay, so that's a dietary issue. We know that her oral hygiene could be improved, and she had an elevated Caries screen score. So if we go then to look at the usual suspects here, she has all 3. She's got saliva, diet, and biofilm. So now what are you going to do for this patient? What would you recommend? She's got a dry mouth. She's got a dietary problem, and she needs to improve her home care. So what are you going to recommend? So she's high risk. She's got a lot of cavities at the moment. She's got a lot of active decay. So certainly I'm putting her on a fluoride varnish every 3 months. Okay, that's a number 1. That's an always, like I told you in my protocol. Probably going to put her on an antimicrobial strategy. I'm going to add 5,000 part per million fluoride gel, pH xylitol, nano-HA. I may or may not use silver diamine fluoride, depending if we're just trying to arrest a few of the cavities and stop their progress while we kind of work on others. If we want to phase some treatment, I may or may not use that for her. That's really patient dependent. And then coaching. What are you going to do to coach this patient? How are you going to, what are you going to tell her? How are you going to get her to work on her risk factors? So here's the strategies for me. 3-month fluoride varnish, like we said. I want to know what you're thinking, but follow with me here. I'm putting her on a fluoride gel. I'm going to use an antimicrobial strategy, and then I'm going to talk to her about her dry mouth, trying to stay hydrated. I'm going to talk to her about the challenge she's got with both the amount of sugar that she's consuming in terms of the sugar and the creamer in her coffee, and again, the frequency that she's consuming that, because she's sipping it all day long. So she's keeping her pH below the healthy recovery and the Stefan curve, like literally all day. And then, we need to talk about home care. So which one of those would you have her change? What would you have her work on first? Would you have her work on managing the dry mouth? Would you have her work on changing her diet? Would you have her work on her home care? See, these are the issues. These are the kind of decisions you got to make when you're looking at a patient like Darcy that comes into your practice. So let me share with you, when we talk about coaching language, which is one of the behavioral objectives tonight, learning objectives, is in the coaching world, previous to going through a wellness coaching program for a couple of years, I would decide what I wanted the patient to do first. So for her, a lot of times we want to work on their home care. If Darcy's sitting in the hygiene operatory, I guarantee you the hygienist is wanting to work on home care first. I may want to work on the dietary change first. I see that as a huge risk, and it's like, man, Darcy, I want you to change, how you're drinking this coffee and what have you. You need to do this. You've got to change that. And what we learn in the coaching world is what would you like to change first? And human beings are really bad at change. That's one thing that we know. We are complicated beings, and we do not change very well. And we're really bad at it, and we should never try and change more than one thing at a time. So rather than giving, like in the past, good heavens, we wrote a form letter in the first Canberra group that had 19 separate bullet points on what your high-risk patient should now do. These are people that aren't even adequately brushing their teeth, and now we're going to have them follow these 19 things every day? I can tell you it didn't happen. It was a miserable failure. So the most important thing to do is let Darcy decide. Darcy, what would you like to work on first? That's the most important principle I could teach you tonight in behavioral coaching, is let them decide. Do I really care which one she picks? They all need to be worked on, but I want her to decide, because the one that's most meaningful to her is the one that she's most likely to be successful with, and it's going to take 6 months for her to develop a new behavioral change, 6 to 9 months. This is not a 21-day thing. This is a long-term, monthly. This is months for her to make that behavioral change in her life and make it successfully and make it stick long-term. And then we can talk about the next one. And which one is she going to work on next? The one that she picks. Because if I tell her to do something, it's less likely that she's going to be successful than the one that's motivating her herself. And so I want to have Darcy tell me, and then I want to have Darcy tell me, Darcy, what is your plan? And I want specifics. Tell me exactly how you're going to change that and how you plan to be successful doing that. Because if she just says, oh, I'm going to change how I drink coffee, and that's it, what are the odds that she's going to be successful versus her saying, okay, so here's what I'm going to do. I'm going to go to the store tonight. After I leave your office, I'm going to buy some sugar-free creamer. I'm going to buy some stevia to add to the coffee. I'm going to mix it into my coffee in my first cup in the morning. I'm going to try and drink it within a 20-minute span. I'm going to have one more cup of coffee at my break in the morning. I'm going to try and drink it quickly, and then I'm going to maybe have one coffee late in the afternoon. And then I'm going to make sure that I do this. I'm going to write notes to myself, and I'm going to put it on my desk to remind myself that and so that person is more likely to be successful at that behavioral change, having a plan that they designed for themselves, than you telling them what to do or them just saying, yeah, I'm going to change that. Yeah, I'm going to improve how I do that. So it's like they need to have a plan. And so that's the language, the coaching language, that you need to have the patient articulate specifically for you. So we've been through case number 1. I hope that made sense to you. I know you guys are going to probably have some questions there. But essentially, I'm going to turn this over to Kendall. So go for it, Kendall.
Okay. So as we wrap up Darcy's case, we want to take a moment to just reflect, give you guys a break to ask some questions. So as you think about what Dr. Cooch just presented, and more importantly, I think about the format in which he presented it, right? So it's about this process that we're creating to make it duplicable in your own practice. So think about that. What stood out to you in this case? Was there anything that was an aha moment, anything that you may have done differently, or just in general, how is this approach different or similar to what you're currently doing? So feel free to chat in. We're going to watch the Q&A, and as we continue on, we'll pull some of these questions out and talk about them. We'll have Dr. Cooch answer a lot of your questions, so feel free to chime in anytime. And Dr. Cooch, we did have one question that came in from Dr. Fondrick. He asked, can you explain why Caries, so this is a little off subject, which is totally fine, but I think it's a great opportunity to stop and ask the question. He said, can you explain why Caries' activity seemed to decline after the teenage years?
No, I can't explain that. I can offer you several theories on why we think that is, but in truth, do I know why that is? No. Other than I think, one of the theories is that their oral hygiene isn't as good in adolescence, and I know you see that. Their diet may not be as good, during their teenage years, although I tend to see patients come back from, their first or second year of college who have been decay-free that now have tooth decay because their diet changed while they were at school on their own. And the other one is that, and this is a long-term belief, that once you restored those susceptible surfaces, once they've been restored, well then they're kind of stabilized for a period of time, and it's less likely that area is going to decay again. The restoration isn't going to decay, although obviously we all know that certainly recurrent decay is an issue. And so it could be growth and it could be some growth and development going on in there as well. The one thing that we tend to see is like their young adulthood, like 20s and 30s. Tend not to have as much tooth decay, but then they, get into the 40s again and they start taking more medications, have more health issues. You dry out the mouth, and again, maybe their diet changes again as an adult, and they make those changes in their lifestyle, and we start to see the decay rate go up again somewhere in their 40s and 50s and really accelerate in their 70s and 80s, and I really blame that on medications. The patients, they get in their 70s and 80s and they're taking 4, 5, 6, 8, 10, 15 medications every day, and we see things go downhill very quickly from there. So there's all of that going on. The other thing that I would tell you right now that I'm seeing as well, and see if you see the same thing, I think for the millennials, for the Y generation of the millennials, my children, basically they're in their 20s, late 20s, early 30s. That generation fluoride worked for. And so we've got a whole kind of generation moving through that had the benefit of fluoride. The fluoride seemed to work well for them, and they're pretty much decay-free. So we've got a lot of people in their 20s and 30s right now that have, literally have had very little or no decay. And what I'm seeing now is in their children have a lot of decay. They had decay like I had when I was a child before fluoride, and yet we're using higher and higher levels of fluoride now than we ever did, and yet we see this growing epidemic of decay, which has been going up by double digits. The CDC reports every 4 years, until this last report is the first time it appears to in our adolescents leveled off, plateaued slightly, and maybe even slightly declined, but it's been increasing in our adolescents by double digits for the last 30 years. And I believe the bacteria, quite frankly, are learning how to evolve and adapt around fluoride. So, I mean, that's just a personal belief, but it tends to fit what I see. And again, the other thing, we've got probably a lot more sugar in our diet today for these kids than we had, say, 30 years ago, and we probably have more medications that these kids are taking a day. We got 17 million kids in the U.S., adolescents, 0 to age 17, that are on psychotropic drugs, and that doesn't include all the asthma and all the antihistamine medications, GERD. We're identifying GERD in infants now at age 6 months of age and treating it with medication. So it's like, I think there's a lot of that. So all those risk factors that we're talking about are starting to happen earlier in these kids today as well. So it's a complex issue, and I don't think we don't know the answer to that, but it's a great question. So I really appreciate you asking that. So Kendall, I think perhaps we should probably move on to case number 2.
I think you're right. So we'll move on to case number 2. We see a lot of other really great questions coming in. We'll have some more recap time where we can come back and answer some of those questions. Okay. So Dr. Cooch, if you want to click the arrow, and then you're good to go.
All right. So meet Lorraine. Lorraine is a 62-year-old female patient. She has normal blood pressure. She's got a pretty good pulse. She's not taking any medications. She has no health issues. Okay, so again, you should be thinking saliva, diet, biofilm. I mean, that should just be, I want that to become like a automatic saliva, diet, biofilm. So I just want you to start. What do you see? Do you see saliva? Yeah, she's got saliva bubbling in the back of her mouth. Her tissue is wet. Yep, that's exact. She's got saliva kind of coming in between her interproximal spaces. This is a person that's not taking medications, doesn't have a saliva issue, right? So, I mean, this is what you're looking at. Do you see decay throughout the mouth? Do you see a lot of biofilm on her teeth? Does she have pretty good home care? So those, that's immediately what I'm looking at every time I look at that patient. You just think saliva, diet, biofilm. That's your mantra. And here's her radiographs. I'll give you a second to look at those. Looks like we could have a little better margin there on number 20. That's about it. So here's her risk assessment form. She has answered yes to 1 risk. She snacks daily between meals. So we're going to want to ask her more about that. And instead of asking, this is really important, again, coaching language, instead of asking yes or no, closed-end questions like, what do you eat? What are you snacking on? I want to say, oh, okay, that's interesting. So tell me about tell me more. Tell me about that. Tell me what kind of things do you snack on? Tell me rather than a yes or no. I want them to I want to draw it out of them. Tell me. And if you have somebody ask you, hey, oh, that's interesting, tell me more about that. You know what? They're going to tell you more about that, and it's non-judgmental, and that's the most important way to phrase that for the patient. So she's answered no on all those questions except for that. She has a low Caries screen score. She has no disease indicators. So let's go back to the Caries risk assessment form. What is your diagnosis here? And so remember, if they have only green answers, they're low risk. If they have at least 1 blue answer, which is a risk factor, that makes them moderate risk for dental caries. If they have at least 1 red answer, that makes it high risk. So Lorraine here is moderate risk because she has a risk factor. She doesn't have any cavities. She doesn't have any white spot lesions. She's got plenty of saliva. So what we really need to do for Lorraine is figure out what our assessment is. And so I think at this point, you guys are all onto what her big risk factor is. So what usual suspect does Lorraine have?
So we're going to take an opportunity now. You guys are really great engaging with us on the computer, and you already know what to do. I don't even have to tell you. So cast your vote. Tell us what you think the usual suspects are for Lorraine. I'll give you guys about 15 seconds, and then I will broadcast the results. So 15 seconds is going to go really fast here.
This is awesome, by the way.
It is. I still see some people casting votes. Okay. I'm going to wrap it up right now. Sorry if I'm cutting you off, but we're going to broadcast what we have here so far. We're close. Okay. So I ended the poll. So we had 25% of you chose diet and biofilm. 71% about chose diet. And we had a few people that chose saliva and diet. So Dr. Cooch, I will send it back your way to reveal the answer.
Okay. So this is solely, if we go back to the risk assessment form, actually let me go back real quick. So if we go back to the risk assessment form, she has just strictly her only risk factor here is diet. She answered no, she doesn't have a saliva problem, she has plenty of saliva, she's not taking any medications, doesn't feel like she has a dry mouth, she's got saliva in her mouth, so she does not have a saliva issue. She did answer yes to the diet because she snacks between meals, and we need to find out what that is. And she doesn't have a biofilm issue because really she doesn't notice plaque buildup on her teeth. Her hygiene is very good, and she had a low Caries screen score. So that's telling me there's no biofilm issue going on here. She just has one risk factor. She doesn't have any decay. She doesn't have any issues. She's just at risk for decay because of her snacking between meals. So when we talk about this, so she's just moderate risk, and she just strictly has one risk factor. Now it turns out when I'm asking, so tell me about the kind of things that you like to snack on during the day, and she says, well, I'm a chocoholic, and I eat only 72%. I mean, she's a serious chocoholic. Only dark chocolate has to be a minimum of 72%, and but I'll eat it, periodically throughout the day. And I'm like, okay, so you don't have any decay right at the moment because of this, but it's putting you at risk by eating that snacking frequently. The dark chocolate certainly isn't as bad for you as, say, milk chocolate. It has a lot more sugar in it, but even so, even 72% dark chocolate has sugar in it. So it's like if you want to minimize your risk around that, the recommendations that I would have to make, and is it okay if I offer you some ideas on what I would do? Because I don't want to tell her what to do. And if she says yes, then I want to make sure she understands it's both the amount of sugar that she's eating during the day, and then it's also really the frequency. It's the snacking frequently 2 or 3, 4 times during the day, eating this, that's causing the pH in her mouth to drop, which favors these bacteria, which with any other right now she has enough saliva, everything's great, but if she started taking an antihistamine or she started taking a blood pressure medication 2 years from now, 5 years from now, suddenly, I mean, in a span of 6 months between her checkups, she could come in and have like 2 or 3 new cavities and have been decay-free for like 40 years. So I want her to understand, that's why I'm having this conversation. I don't want you to come in and have cavities and be surprised. I want you to know why we're going to talk about this every year. And if I can offer her suggestions, what I would do if it were me is I'd figure out how much dark chocolate I need every day for my health, and I would try and clump it together in episodes where it was like maybe once in the morning and once in the afternoon. And again, come up with a plan on how you're going to remind yourself to do that. Guys, with all of the smart watches and our phones, I mean, you can set reminders and prompts for yourself. I mean, those are really great tools for making behavioral change. So her risk assessment here is diet. So what kind of things would you do for this patient? If you go back to my protocol for a moderate risk patient, what would you recommend for Lorraine in terms of fluoride? Would you do fluoride varnish once a year? Would you recommend it? Would you offer it? Would you offer or recommend being on some products that might have higher levels of fluoride or have xylitol or nano-HA? Certainly she does not need silver diamine fluoride. She doesn't have any lesions. And then with the coaching, again, how would you talk to this patient about the chocolate and the dietary issue? And so here's what I would do. She's moderate risk in my practice. I offer her a 6-month fluoride varnish, which she does, by the way. I recommended this fluoride, xylitol, alkaline pH, nano-HA gel, and then talk to her about her risk in terms of consuming dark chocolate and helping her understand that she can still consume the chocolate, but she can make it less risky for herself by eating it differently. So that's kind of how I would approach that. How'd everybody do with that? Did everybody kind of follow that? Again, what
Yeah.
what I really want to train you to do is to just think saliva, diet, biofilm. I just want you to think that way. Saliva, diet, every time you look at one of these cases, just think to yourself, saliva, diet, biofilm, and answer those questions in your own mind, and then look at their risk assessment form, and that'll lead you right to what's causing their disease, and then asking the open-ended, non-judgmental questions, tell me, that's interesting, tell me more about that, or say more. That's non-judgmental, and people will really respond well to that. So everybody do okay there?
I think everybody did okay. I think as we look back at Lorraine's case, one thing that I think a lot of doctors and team members might be thinking is, okay, this is a moderate risk patient.
Yep.
Is this really necessary for them? And so a question that we would pose to all of you, are you currently discussing Caries risk at all with your moderate risk patients? Do you have a process in place where you can identify, even if the only thing that's happening is they're snacking on dark chocolate frequently and their biofilm activity is maybe right on that tipping point, is that discussion taking place? And if not, what are the barriers in your practice? Is it a time issue? Is it, a confidence issue? Do you see the value that it brings to patients? Talk to us about what some of those barriers are. And I don't know, Dr. Cooch, if you want to touch on the value that you find in your practice and why you would do this and have this conversation even with a moderate risk patient.
Yeah, and the reason that I do, Kendall, and is extremely valuable, is because human beings are complex and they change. Our health changes, our situation changes. People go through divorces. They have a death of a spouse. They have, their children leave home. I mean, we go through all of these. They buy a new house. They file bankruptcy. We have all these issues that go on in our life, and when those things happen, a lot of times we fall back on some comfort habits, whether it's diet or we fail to brush our teeth or stop flossing, or we start taking medications because suddenly we're 45 and we're developing hypertension. So these things change. Risk factors change for patients throughout life. So it's really important for everyone, even my low-risk patients. I want to know every year. I'm going to have you fill out this form. I want to know every year, because if you start taking a medication that could severely affect you, and I've had this happen to my patients, 6 months later, a year later, you come back in for your checkup, you're low risk, you haven't had a cavity in years, and all of a sudden you got 5 cavities, and maybe I'm extracting 2 teeth. I mean, I've had those experiences. So if I can help that patient know ahead of time, oh, that's right, I'm taking this medication, I should call Dr. Cooch and ask him about, what I should be thinking about or what I should be doing. I think I mentioned the patient earlier that I saw today, a new patient. The lady is a sweet lady. She's 67 years old. She had a stroke 2 years ago. She'd had a history of decay, but she's been decay-free for years, and she has pretty adequate oral hygiene. But she started taking like a whole page of medications as a result of her stroke, and then her physical ability isn't what it was prior to the stroke in terms of being able to, brush her teeth and floss. And her mouth was extremely dry. She carries a water bottle with her, but so she started sucking on hard candies 2 years ago. And now she's going to have, 80% of her teeth extracted. This happened, she had healthy teeth up until 2 years ago, and now she's losing 80% of them. And I got to see her today, and I explained to her what happened and why it happened, because nobody else would believe her. Everybody thought that, she'd seen a couple of dentists who told her that, well, you're not taking good care of yourself. No, these cavities couldn't have occurred in 2 years. And it's like, no, this has been going on for a long time. Nobody listened to her. And I said, listen, you need to understand, this is not your fault. yes, you made a mistake by sucking on the hard candies. That was your remedy. But it's like, but you had a dry mouth. You didn't have that before you had the stroke. I believe you. I believe that you had healthy teeth up until 2 years ago. And now, we're scrambling to try and figure out how we can, help her. But now she understands, right? Unfortunately, she didn't understand that 2 years ago, because if she had been educated through her practice, through her existing dentist, that it's like, you start taking medications, I need to know, because if you have a dry mouth, this is going to put you at risk for having a lot of tooth decay. You need to, like, that happens, you need to start telling. She says, why didn't my physician tell me this? Why didn't my physician refer me to the dentist and say, look, you're going to have a dry, you're taking 6 medications, you're going to have a dry mouth? And I go, I really apologize. That's the state of our healthcare today. I'm sorry. We're all trying to we're all trying to get better, but I'm sorry that we're not better than that. But that's where we're at, and but that's the value. But that's the value of that, is educating that person before it happens, so that when they have the changes that occur in their life, it's not catastrophic like it was for this poor lady today.
Absolutely, and I'd like to read. I don't know, Dr. Cooch, if you saw the comment. But Joy Foster said she had a patient that was caries-free for 20 years, and the patient ended up getting a cold/cough and was a nurse in the hospital recovery room, and she sucked on cough drops nonstop for 2 weeks. And she came back to a dental appointment, and at her very next appointment, she had an interproximal cavity. So that situation, that's a reality for sure.
It's a reality. We all see that, yeah.
Okay, let's move into patient number 3. This is all really good discussion. Okay, and you are ready to go forward.
This is reality. These are the patients that we see. So let's move on. Meet Chad. Okay, so Chad walks into your door tomorrow morning. He's a new patient. He's 46 years old. His blood pressure is a little elevated there on the systolic. His pulse is kind of normal. He hasn't been to the dentist a whole lot. But, he knows that he needs to, and he's having some issues, and so a tooth broke there in the front. Thought it was time maybe to get in. So, again, what are you thinking here? And I want you to think systematically. Saliva, diet, biofilm. So I'm looking for saliva here. I'm looking at the diet. Do I see decay spread all throughout the mouth? I'm looking at biofilm, and I'm looking here to see, is he got a lot of plaque buildup on his teeth? So that's my first, that's the thought process I'm working on. So here's his radiographs. We all look at it. It doesn't take long for experienced dentists to look at radiographs, and you see everything that I see here. I know you do. So let's look at Chad's Caries Risk Assessment form. Are you taking any medications? No. Do you feel like you have a dry mouth at any time of the day or night? No. Do you drink liquids other than water more than 2 times a day between meals? Yes. Do you notice plaque buildup on your teeth between brushing? Yes. Okay, so out of the gate here, I know that you guys are identifying the risk factors here, the usual suspects. When we look at then, he's got it all there. He's got the high Caries screen score. He has cavitations, new cavitations, interproximal radiographic lesions. He has new active white spot lesions. His decay history is a concern. He has at least 1 red answer, so that makes him, let me get on the arrow. Getting used to this new software, so that makes him high risk. So if you said high risk, you were absolutely right on. So what's your assessment here? Again, it's what Chad has told us is it's diet and biofilm. So what he lets me know, and I start asking, so, I find that interesting. You answered that you drink something other than water more than 2 times a day. Tell me more about that. He drinks Mountain Dew like nonstop all day long. Probably drinks 6 to 10 Mountain Dews a day. Well, Mountain Dew is, based on studies, contributes to more mineral loss from teeth than any other soda or any other sugar-sweetened beverage at all. So Mountain Dew is kind of the biggest risk factor here. And then his hygiene is poor. So his Caries screen score was high. He notices a plaque buildup. So again, when we talk about this, he's got a diet and biofilm. So if you follow that assessment, you're right on. What would you do for Chad? What are you going to, so he's high risk. What's your protocol for high risk? What are you going to do for fluoride? You're going to use fluoride varnish? How frequently? Would you use an antimicrobial agent with Chad? Are you going to recommend a 5,000 part per million fluoride gel with xylitol and nano-HA and an elevated pH? Are you going to use silver diamine fluoride on this patient? And how would you approach the coaching, for both the home care and the dietary changes that Chad's going to need to make? So, what kind of things would you recommend for Chad? And Kendall's going to give you about
15 seconds.
15 seconds. We should be able to play the music from da 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 da.
From Jeopardy.
Final Jeopardy. We should have the Final Jeopardy music going in the background.
That's right. We upped the ante on this one. We made it just a little bit harder, but you guys have some good answers here. Depending on how wide and how big your screen is, you might have to scroll down to see all of the answers here. But it looks like most of our answers, I'm going to broadcast the results here so you guys can see what's coming in. So most of our answers are all of the above.
Yep, and I mean, Chad is somebody, of course, this is up to you. This is your practice, and it's up to you to make your own protocol. In my office, for Chad, he's going to get a 3-month fluoride varnish. I'm throwing the book at him. He's getting the gel. He's leaving with that, 5,000 part per million gel. I'm going to send him home with an antimicrobial rinse. We're going to start on that as well. And then, we got to start talking about behavioral coaching, for changes in both his home care and the Mountain Dew. So the question of the hour then is, which one are you going to recommend? How are you going to approach the behavioral changes for the diet and the biofilm? Which one are you going to have Chad work on first? And we're going to go back to
Dr. Cooch, sorry to interrupt you, but this actually brings up a really good question that I've been wanting to ask from Dr. Jeffrey Mayer. He said, and this was early on as you were talking about behavioral coaching, his question is, how do you treat patients who decide on the needed changes so slowly that massive damage continues?
So then you got to have a frank conversation with the patient about, okay, and it's okay, behavioral changes, 2 steps forward, 1 step back. As long as I see continual progress, that's okay. But if you've got somebody, what you can see that I did here with Chad was I used silver diamine fluoride. So all those areas that were kind of dark brown are now black. And so to Chad, I explained to him, here's literally, Chad, man, we got a lot of work to do here in terms of, restorative dentistry. It's going to cost a lot of money. We can lay all that out, but in the meantime, while you're working on the other things, I need to freeze this. I need to get my fingers in the dike so that you and I have time to phase this treatment out. And you have time to work on your diet, and you have time to work on your home care. So the question for Jeffrey is, what do I do? I sit down and have a conversation about, we're losing ground here. It's not, it's not working fast enough. Things are getting seriously worse. I'm concerned about that. Here's a potential solution that could help us, but here's the downside to that. Like there's a lot of patients, like here's Chad, when I said, yeah, these are going to turn black, and he looks at me and he goes, I don't care. But Darcy may have said, oh, no, I don't want that. I don't want that on my front teeth. I don't want to have black teeth. I work with the public, So for some patients, that's an option, and for some, it's not. But you got to have that frank conversation about, we're losing ground here, and so we need to talk about that. What are we going to do? Because I see the cavities getting worse. Maybe you're going to need a root canal before I can even get to restore this tooth. You just need to be able to, how can I help you reinforce those changes? So, and then that's the role of a coach as well. Let you know, hey, you're slipping up here. It's not working, and how can I help? How can I help you? Right? How can I help this? Because if we don't change anything, if it doesn't change, you're going to lose more teeth, or you're going to need more root canals, or whatever. So that's kind of how I approach that. That's a great question, by the way, because again, I mean, I've got one patient that comes to mind that I worked on for years, and we finally got her healthy, but her home care brushing was just the biggest issue. And it took 5 years for her to really develop brushing habits that kept her from being at risk for dental caries. But, we'd make progress, and then she'd do better, and then she'd slip back. And then we'd make progress again, and she'd slip back. You got to realize it's like, they're got to be adults. They're responsible. It's their teeth. They got to take care of them, but we got to be able to kind of help coach them through that. Great questions, by the way. This is awesome.
Absolutely. So think about, oh yeah, go ahead.
I was going to say, so are we ready to go to the next case?
Yeah, absolutely. And the webinar is scheduled to go until 6:45, but of course, we know, a lot of you are on the East Coast or in Central Time Zone. So if you have to jump off a little bit early, no worries. We'll finish up through case 4. We should be wrapping up around 6:45, so if you can stay with us, we'd love to have you.
Okay, so let's meet Kyle. Kyle's 26 years old. He walks into my practice about a month ago. He's come to see me because he's getting married. So, when he talked about some of the changes that occur, Kyle comes in because it's like, man, I'm getting married, and, my bride is like, man, you got to get your teeth fixed for the wedding because, we can't have these wedding photos with you with broken front teeth and these black teeth and these holes in your teeth. So, like, you got to get this fixed. So Kyle comes in, and he's getting married in a month. Which I was happy that I had a month because a lot of times they come in and, I'm getting married on Saturday and I got to do something. I had that happen just actually in June. Father of the bride comes in and, my daughter's getting married on Saturday. It was like Wednesday. And, I'm like, oh, man, it's like I'm going to do what I can for you, but, we're going to be doing a lot of work after the wedding, but let's just do what we can before then. So Kyle here is taking Wellbutrin. He has high dental anxiety, and he has not been to the dentist, as you can see, because of the anxiety. So here's his radiographs, and his concern right at the moment is I just got to have the front teeth look good for the wedding photos, and then I will commit to come back and follow up, and I want to stop having cavities. I'm getting married. My wife wants me to have a healthy smile. So, number one, are you taking medication? So again, what are you thinking? You're thinking saliva, diet, biofilm. I mean, just, God, write this on a notepad and stick it in your operatory. Just saliva, diet, biofilm. Just get to thinking that way. So saliva, yes, he's taking Wellbutrin. You see somebody taking Wellbutrin, I got to tell you, they got a really severe dry mouth. That's a huge risk factor. Do you feel you have a dry mouth during any time that? Yes, he answered. Do you drink liquids other than water more than 2 times a day between meals? And he answered yes to that. He doesn't snack. And he noticed the plaque. He knew he had plaque buildup on his teeth. He knew that it was, he needed a cleaning, and he knew that. So, there we go. Risk factors. Where are you going with this? So let's look at the rest of his risk assessment form here. So he has a high Caries screen score, he's got everything, right? So again, is he low, moderate, or high risk for dental caries? If you have at least one red answer, you're high risk. It's just simple. So Kyle's high risk, and your assessment is he's got a saliva issue. We know he's got a diet issue. We're going to ask him about that in a non-judgmental, open-ended question. We know that he recognizes he's got, a biofilm issue. So it turns out he's got a dry mouth from Wellbutrin. And I tell you, when you see somebody taking Wellbutrin, remember that drug. That's a serious dry mouth. He drinks Gatorade throughout the day. Started drinking it when he was playing baseball in college and thought it was healthy, it was good for you, so that became his drink of choice during the day because it was a health drink. And he's an athlete, and he's fit and what have you, and he's got a high Caries screen score. So again, if we talk about the usual suspects, he has all 3, saliva, diet, and biofilm. Now the question becomes, what are you going to do for Kyle? Okay, so again, I want you to think, have a system in place. Like I have a protocol. If they're high risk for dental caries, they're always getting a fluoride varnish, right, every 3 months. And so Are you
So
going to
we'll
use
do
an
another,
Yep,
do
we're going to do
poll
another
here, and
survey.
as Dr. Cooch is talking, feel free to type in what answers, what therapeutic strategies you might recommend.
And I'm liking those answers. You know, Kyle is somebody you can throw the book at, right? I mean, throw everything at him. Obviously, you can't, you know, you're just substituting. I want you to use this gel instead of your toothpaste. I want you to use this mouth rinse. Start using it. So there's already, we've added something new for him that I expect him to do that he wasn't doing before. So I've already made one behavioral change for him, right? I'm going to get him back. We're going to put on those posterior teeth, I'm putting silver diamine fluoride on those. I want to arrest that decay. You know, I got to make his front teeth look good for the wedding. Okay, yep, we're going to follow that. You know, we're going to put him on that gel. And then it's like, okay, Chad or Kyle, you've got to work on, you know, your home care, your Gatorade. You know, those are the things that you're going to need to work on over time. Which one, you know, I don't care right now. If I can just get him using the antimicrobial rinse, that's step one for me. If he said, yeah, I would like to start working on the Gatorade, or I want to really work on getting better at brushing and flossing, whatever he wants to do first, that's where we're going to go with this. But right now we got the holes filled, we got his teeth cleaned up, we got him ready for the wedding, and you know that's step one. And then we're going to be doing the rest of his work over time. So that's kind of his strategy there. My strategy for Kyle. Again, so, you know, Kyle's the kind of person that you can literally kind of throw the book at. But you can't add to, you know, I've seen speakers say, okay, I want you to choose 5 sticks of xylitol gum every day between meals. I want you to start brushing with this electric toothbrush. I want you to use this gel. And then I want you to use this mouth rinse. And then I want you to floss. And then the 5 sticks of xylitol gum. And then at lunch, I want you to rinse your mouth out with water. They give them a list, again, of the 19 bullet points of what I want this guy to do. It's not going to happen. In fact, after the, you know, halfway through the first day, he's just going to throw his arms up and go right back to what he was doing before. So you just need to focus on one change. Kyle, I'm asking one thing. We really need to have you on an antimicrobial agent to knock your biofilm count down until we get to work on everything else. I want you to use this toothpaste instead of the one you're currently using, and I'd like to have you add this rinse to it. And so we talk about that. And then if he wants to work on more, that's up to him. But I'm going to take this like one change at a time. So that's kind of the 4 cases. I know you guys see these patients. I mean, I see them. I know they come into your office. And so the whole key here is trying to understand why. Why does Kyle's, if you could be the investigative journalist here, figure out why, play Columbo, figure out why Kyle's mouth looks that way. Because if I can figure out specifically why he has those cavities, I can help him, I can coach him, and I can help him not only, you know, we can restore all that, but we can help him understand how he can be in control of his health and become decay-free and be decay-free for the rest of his life. So that's the most important thing that you can do for patients. And again, I just want you to, this is the mantra, I want you to, I want you just to wake up in the middle of the night and have this going through your brain. Saliva, diet, biofilm. I want you to be haunted by my voice. Saliva, diet, biofilm. But it's the mantra because I just want you to think that way, because if you think that way, you're going to come up with these answers, and it'll be a little awkward at first, but the more you do it, the easier it gets, and the better you'll get at it. And I tell you, it's the most rewarding thing that you're going to do in your career. So anyway.
Absolutely. Creating that pattern recognition that allows you to then create the standardized process and then just repeat it over and over and over with all of your patients.
So that's it for tonight. Kendall, correct?
Mm-hmm.
We have a few questions.
Yep.
So so this is the first time for us, and I appreciate you guys all being with us tonight and going through this whole webinar. What I really want is feedback, because I do this for you, and so I'm trying to help you get better, learn how to do this, be able to implement this seamlessly into your practice, to make it simple, to get you to think, get inside of my brain and think the way that I think when I see these patients, so that you can get better at doing this. So what I really need is your feedback. I mean, for us, I thought it was wonderful tonight because I loved seeing answers and seeing people be interactive and, you know, asking you questions and making you think, and you do the diagnosis and you do that, and you come up with a treatment plan, because I think that's a much better learning model than me just sitting here telling you about stuff every quarter. So, but I'd like to be better at this. So please give us your feedback. If there's improvements, something you'd rather see, or you'd rather see us present this differently. I mean, if you loved it, tell us. If you hated it, tell us, because like literally, I come here and do this for you. So I want to make it as effective for you as I possibly can. I want to be a resource to you. So that's the one request that I have tonight, is just give me your feedback.
Absolutely.
Kendall, I want to thank you. I thought it was fun.
Yes, absolutely. Thank you to you as well. And we'll continue to refine this process. We do have webinars every quarter, so we'll be posting the date for the next one and the topic. So be on the lookout for that, and we'll continue to improve what we're doing on our end, but we can only do that with your feedback, so please let us know, like Dr. Cooch said, you know, what you're most interested in hearing about and the format of it. A couple of wrap-up items before we let you guys go. If we didn't get to answer your questions tonight, please look out for a response from us within the next few days. We do want to make sure that we respond to all of you, because we appreciate your engagement and taking the time to ask those questions. We will be sending out a recording of the webinar, so if you'd like to watch it again or you want to share it with colleagues, you're welcome to do that. We also did introduce our new risk assessment form, which was just released back in May, but this is kind of the first official release of it. So if this is the first time that you're seeing it and you would like a copy, you can download it in the Files to Download box in kind of the middle bottom part of your screen. Or you can just contact us. We'd be happy to send it to you. Dr. Cooch's slides are also there for you guys to have, so you're welcome to download those. If you are re-listening to this as a recording, you will still be able to download the forms and the slides. So they will remain active, and you can just click on them within the box here in the middle bottom portion of your screen. Click Upload File, and it will save it onto your computer. Last but not least, we always offer our practices live one-on-one webinars. So if you're new to CariFree and you want to learn more, or if you're not new to CariFree and you feel like it's a good time to schedule a refresher training for you and your team, please contact us. We have a whole team of people here that would love to sit down with you and your team and walk through, you know, any of this information, help you design and build a customized protocol in your own practice. That's what we do. So please don't hesitate to reach out to us. I think that covers everything. I know we covered a lot of information. It was a lot of fun to be with you guys tonight. Dr. Cooch, do you have any last-minute thoughts before we let everyone go?
Nope. I just want to thank everybody from the bottom of my heart of spending your time with me. So I really do not take that for granted, and I really appreciate it. So thank you for being with us.
Excellent. Thank you. Have a wonderful night.
Good night, everybody.